My topic for today's discussion is regarding EECP technology, that is enhanced external counter pulsation therapy. This topic is really important and really useful for all of us because this therapy or technology has become a headache for all of the cardiologists, because a lot of these marketing people are promoting this as an alternative to an angioplasty or an bypass surgery technique. They also have shown the people that the technology is US FDA approved, although people don't realize what exactly the indication the US FDA has approved this technology for. People don't realize this fact, but people tend to feel that the entire technology is US FDA approved as a replacement for angioplasty and angioplasty. So these are the things which we will be discussing: why exactly there is no scientific basis of this therapy, why this technology is completely useless for all practical purposes, and it's perhaps the most important thing which people tend to ask us in our day-to-day practice, because the ECP technology is promoted so much by these non-cardiologists and the non-interventionists that it has created a huge market, and people have started using it for the wrong reasons in the wrong places, and a lot of people actually end up going for an angioplasty or bypass at a later date, or they end up dying at their homes because of taking the wrong therapy for the wrong reasons. People tend to believe that some natural bypass has occurred and some natural collaterals have opened up, which obviously doesn't have any scientific evidence. But people tend to believe these facts, and the reason why people tend to believe this fact is that in our country people tend to feel that anything which is promoted as natural is good for the health. Whether that has any scientific basis or it doesn't have any scientific basis, people care least about it. People only think that anything which is natural is good for the health. Natural is the best. However ineffective it might be, people tend to feel that it is good for the health. That is why the therapy which has been promoted as a natural bypass is considered by people as an alternative, as a replacement for angioplasty and bypass surgery. And this is what we'll be discussing in due course of the next few minutes. What exactly is the technology, how exactly does it work, and why this technology is completely useless for majority of the patient. This topic is going to be extremely interesting and useful for a lot of you, so I would request you to see the topic till the end. And the people who are new to my channel, I would request them to subscribe to my channel, as this will give us a lot of inspiration and motivation to continue the good work as we are doing now. So first of all, what exactly is a blockage? Blockage is development of a cholesterol containing plaque inside the coronary vessel, which causes restriction or obstruction in the blood flow depending on the severity of the blockage. Usually cholesterol in the vessel starts to get deposited layer by layer from 10, 20, 30, 40%, and once it gets beyond 70%, it causes a significant problem, and people start to develop exertional chest pain or dyspnea, and that point of time it usually does require a treatment. The more is the severity of the blockage, the more is the chances of developing a heart attack, and the more is the likelihood that the patient will require a treatment. Angioplasty is basically the technology wherein we put a wire and we put a balloon across the blockage, and then we deploy a stent inside the blockage. This usually keeps the dirt or the muck or the cholesterol related plaque to the sides of the vessel and opens the vessel and creates flow area for the flowing of the blood. Surgical bypass is the technique wherein from the aorta or the main vessel, surgeon creates an artificial bypass channel, and that is connected to the distal part of the vessel, so that blood directly enters from the aorta into the distal vessel and enters the native vessel and gets perfused into the collaterals or the channels which are connected to the natural vessel, and it perfuses the tissue. Usually the concept of a bypass surgery is similar to what is seen in a road bypass, because in a bypass road what we do, that from the highway to highway we create a bypass channel. If at all the traffic in the city is too much and we do not want the highway traffic to enter the city, we create a bypass channel so that the traffic moves from the highway to highway and doesn't have to enter the city. So the concept is same with a surgical bypass, that the surgeon creates an artificial channel wherein the blood can directly flow from the aorta into the distal vessel. Now, what is natural bypass or collaterals? Basically, collaterals or natural bypass, what they call it is the presence of multiple microcirculatory channels which are present inside the native vessel. These God itself has created multiple microvascular channels which are present inside the vessel. Actually, the main vessel cannot supply so many branches that it can perfuse the entire tissue. So God has created multiple microcirculatory channels for the entire vessel. There are millions and trillions of small collaterals channels which are present inside the vessel, and they supply perfusion or blood to the entire tissue from the native vessel. But the problem with these natural collaterals or natural bypass tracts, whatever they call it, the microcirculatory channels, are that they are so small that they cannot generate adequate tissue perfusion pressure which is required for the blood to enter into the tissue. Usually the microcirculatory channels, if at all the collaterals are also developed, and even if they are very good collaterals also, the perfusion pressure is not good, unlike a surgical bypass, because surgical bypass, the graft is connected to the aorta, the main vessel. The aorta is directly pushing blood inside the microcirculatory channels, so the perfusion pressure is high and the blood gets into the native vessel in a high pressure, and that is why it gets distributed in a good way. But if at all the vessel is dependent on collaterals from other vessel which are natural collaterals, usually what happens that the perfusion pressure is not good, the pressure which is generated or the force with which the blood is entering into the vessel is very low, and because of this low pressure the tissue will not get adequate amount of blood supply. Studies have shown that even with the best quality collaterals, which by definition is considered Renitrop grade 3 collaterals, that means the collateral is so good that it is perfusing the entire vessel, or the entire full vessel is getting filled up with the blood from the collateral channels. Even if a Renitrop 3 collateral is present, then too the perfusion pressure will be as good as that which is supplied by a vessel which has a 90% blockage. That means this collateral will only supply 10% of the blood which is required, even with a best quality collateral, natural collateral which is formed. Although this ECP doesn't help in any sort of this natural collateral bypass, natural collateral is usually formed naturally only, but even with the best quality collateral, the perfusion pressure is so low that it only provides 10% of the blood which is adequately, which is actually required by the blood vessel. That is why for majority of these cases, patient will be asymptomatic at rest, because the resting blood supply, which will be only 10 to 20% of the requirement of the body. So patient will have adequate blood supply when the body is at rest. But when the patient starts to exert and walk about and do his daily activities, then the blood supply requirement of the heart increases. If at all the patient at rest, the 10 to 20 ml of the blood is sufficient, then at exercise the blood requirement increases to 50 or 80 ml. By the concept of the collaterals, if at all they are supplying only 10% of the blood, so if at all 100 ml is usually supplied by native vessel, these collaterals will supply only 10 ml. So at resting condition, when this 10 ml is sufficient for the heart will contract normally and you will not develop severe amount of pain. But if at all you are doing walking and exercising, when the blood requirement of the heart is increased, that point of time you will require around 70 to 80 millimeters of blood. This I am using just as an example, because exact requirement is not for 100 ml or 70 ml, but just as an example I am trying to quote this. If at all the blood requirement is increased by 5 to 6 times, that point of time these collateral channels are so small that they will not be able to provide you the blood supply which is adequate to perfuse the tissue and to provide the enough amount of blood supply to the tissue, and then the chest pain and the symptoms will start. So this natural collaterals cannot supply the entire amount of blood which is required by the tissue, and only 10% of the blood supply which is actually required by the tissue is performed. And this is not what I am saying, and you need not follow whatever I am saying is correct. You can search for this in the literature. It is given in the literature how much amount of perfusion is given by this natural collateral. This is only 10%, and this is mentioned in our textbooks as well. Second most important problem is that these collaterals don't come from heaven. They come from the native vessel. The aorta bypass channel which the surgeon is creating, that is coming from the aorta. So that is a bigger channel, but this collaterals will come from the native vessel or the 3 coronary arteries which God has given. If at all you are not treating the coronary arteries and you are allowing them to occlude, then who will supply the blood to the collaterals? Because the collaterals are also dependent on the native vessels to supply the blood. If at all the native vessel has a 80-90% blockage and you are not treating the native vessel and the native vessel goes to 100%, then where will the blood for the collateral come from? Blood, if at all the blood vessel into the entire native vessel will get occluded, so will the natural collaterals get occluded and they will get no blood supply. So effectively, if at all you say some people will argue that the other vessel will supply blood to this area, agreed. Other vessel will supply, perfusion pressure will remain very low, but still it will supply, but that will be only 10%, and secondly the vessel will be completely dependent on the other vessel. What if something happens to the second vessel? If say, one vessel is getting 100% occluded and the blood supply is stopped, and the second vessel now becomes diseased, then it will not be able to supply blood also to that area also. Because beyond 70-80% the vessel itself will not be able to supply the blood to its own territory, leave alone supplying blood to the other vessel's area. So if at all something happens and something the other vessel, the second vessel also gets completely occluded, then you will have a double heart attack, and the chances of you reaching the hospital will be completely zero, because 70-80% of these patients will die at home only. The reason being is that the one vessel, suppose the LAD has got occluded and the blood is getting supplied from the right coronary artery. suppose something happens to the right coronary artery and the right coronary artery gets also occluded, then the right coronary artery, it was supplying a certain amount of area, that will also get no blood supply, and it was previously perfusing the left coronary artery area also, so that will also not get the blood supply. So both areas will get a heart attack at the same point of time, and the blood pressure will drop rapidly. The patient's blood pressure will drop from 100 or 120 to suddenly to 0, and within seconds the patient will die. So it is always recommended to open up the artery as far as possible. There is something known as the open artery hypothesis also, which you can Google and see. If at all the native vessel is kept open, then it can supply microcirculatory channel and continue the blood perfusion, so that in case of any mishap or any heart attack, the survival chances are much better with the patient. And studies have shown that if at all some artery is occluded and we open it up, the chances of the patient living longer and surviving longer are much better with an open artery as compared with a closed artery. Although this open artery hypothesis is also slightly controversial, but and they do not recommend to open arteries in all the patients where the tissue is already dead. In those cases it is not recommended, but if at all the area is partly viable also, they do recommend the performance of an angioplasty to open up the vessel, because even if the collaterals are getting formed, it is much better that the vessel itself provides its own supplies its own microcirculatory channels and it supplies its own collaterals, rather than depending on some other vessel which will also get occluded in due course of time. At some point of time you will actually eventually require angioplasty or bypass, because at some point of time, one after the other, there are only 3 vessels in the heart. One artery gets occluded, suppose LED gets occluded, then RC also gets occluded, then only one vessel will be working, that is circumflex. If that also gets occluded, then eventually the patient will die. So at some point of time you will actually require some treatment. So why wait till the end before the actually scientifically correct treatment? Until that point of time, you will keep on losing your vessels, and even at that point of time, at the end, if you go for an actual bypass surgery or you go for an actual angioplasty, then the results will not be that good, because a large amount of tissue will be dead by that point of time, because these collaterals do not supply the entire territory and significant portion of the tissue will die by that point of time. So if at all very late in the course of the disease, if you still plan a bypass surgery or still plan an angioplasty, then you will lose a lot of your tissue, lot of your heart failure will have occurred by that point of time, and eventually when all these natural bypass and stupid things will fail, then the patient is left to nothing and he will die ultimately.